Thanks everybody for joining us today. I am pleased to welcome Archana Ajmera for our last live Zoomposium webinar of the summer. Archana will be talking about androgen deprivation therapy today. This initial recording that was done live on July 28th was unfortunately not actually recorded, so we are here doing a mock recording for all of you so you can come back and listen to this fantastic presentation later. We will be also reviewing the Q&A that was asked live at the end of the webinar today. We are going to take a hiatus for the remainder of the summer and come back in the fall, date to be announced. If you have liked us and you want to continue seeing this program continue, please subscribe to our YouTube channel. Go to YouTube and search for APP Symposium and become one of our subscribers. Follow me on Twitter at EuroPA_SD or follow at UCSD_urology, and tell all of your friends and colleagues about our program. Listen to us, to our recordings, and keep posted for announcements for the next series. So without further ado, I am going to introduce Archana. So Archana Ajmera is a board-certified adult nurse practitioner and an advanced oncology certified nurse practitioner. She helps treat people with prostate cancer, renal cell carcinoma, urothelial carcinoma, testicular germ cell tumors, and penile carcinoma. Her scope of practice includes collaborating with her physician colleagues in physical evaluations, diagnosis, treatment, symptom management, supportive care, and end-of-life care. Prior to joining UC San Diego Health, Archana Ajmera was an oncology nurse practitioner at UC San Francisco, where she cared for adults with hematologic malignancies and bone marrow transplant candidates, as well as women receiving breast cancer treatment. She was also an oncology nurse practitioner at Massachusetts General Hospital in Boston, where she managed the care of women undergoing treatment with surgery and chemotherapy for gynecologic malignancies. Archana is also a board-certified women's health nurse practitioner. She obtained a master's degree in nursing from MGH Institute of Health Professions School of Nursing in Boston. She earned her bachelor's degree in nutritional science from UC Berkeley. She is a member of the American Society of Clinical Oncology and National Comprehensive Cancer Network. Outside of work, Archana enjoys spending time with her family, dancing, and traveling. Take it away.
Thanks so much, Rachel, and thank you for having me today. So I'm going to take the next 30 minutes to talk to you all about strategies for mitigating toxicity related to androgen deprivation therapy. So just a brief outline of what we're going to discuss. We'll talk a little bit about the epidemiology of prostate cancer, treatment modalities, mechanism of action of hormonal therapy, and then really the bulk of our talk is going to be about treatment-related side effects and strategies to manage them. So we know that prostate cancer is very common. It's the most common type of cancer affecting men, about 191,000 new cases, and of all cancer types, about 10% of cancer deaths are from prostate cancer. The incidence, this is a graph of the incidence on the left by cancer type, and then the graph on the right is deaths. We know that the greatest number of deaths are related to prostate, lung, and colorectal cancers. The good news really is that since 2017, we are seeing a continued decline in the death rate for prostate cancer. And over here on the left, when we look at the incidence rate, this peak really is reflecting, the surge in detection of asymptomatic men that we weren't previously screening. But the good news is also that of all cancer types, the 10-year survival for prostate cancer really is the best. And the reason that it's important to talk about side effects related to the therapy that we give is because men do quite well. And the median age of diagnosis is about 66 years old. And the trends in survival really are attributed to early detection, increasingly effective treatment for both localized and advanced disease. So what are the indications for androgen deprivation therapy? Localized intermediate risk prostate cancer, both favorable and unfavorable patients. We know that there's robust data for giving ADT in combination with radiation therapy. And even those men who undergo a radical prostatectomy, depending on the pathology, we might see that postoperatively they still need radiation and hormonal therapy. Certainly the high risk and very high risk localized disease patients, these are the men who really tend to receive longer term hormonal therapy, like 18 to 36 months. And even these men, if they undergo RP, may have postoperative radiation and long-term ADT. And then, of course, anything beyond that, biochemical recurrence, hormone-sensitive metastatic or castrate-resistant metastatic disease, and even those men who are non-metastatic but have castrate-resistant disease. We know that the toxicity is compounded when we are adding additional modalities of therapy, such as radiation or surgery. So I'm going to start by talking about a case study. This is a 43-year-old man with high-risk prostate cancer. He underwent an RP in 2017, and he had a T3N1 pathology. He was doing well for about 2 years, and then in 2019, he developed biochemical recurrence. And so this patient at the time had no evidence of metastatic disease and was started on abiraterone, which is a CYP17 inhibitor, and Lupron, which is another androgen deprivation therapy we'll talk about. And the recommendation was for about 2 years. And this is based on the STAMPEDE data showing that there's an overall survival benefit in these patients with metastatic and non-metastatic disease. So the types of androgen deprivation therapy, I'm not going to go into too much detail here, but there are several different categories, all of which have slightly different mechanisms of action. The GnRH agonists and antagonists are really kind of the bulk of what we're going to be talking about in terms of side effects, but there are overlapping side effects with the anti-androgens and the CYP17 inhibitors. The GnRH agonists and antagonists really work at the level of the hypothalamus and pituitary gland, where it's blocking the stimulation of the testicles from producing testosterone. So we know that testosterone, about the majority of the testosterone is produced from the testicles, but we also have some component of testosterone being produced by the adrenal gland, about 10%. So the GnRH agonists and antagonists really are working higher up at the level of the pituitary gland and affecting downstream production of testosterone. The anti-androgens and CYP17 inhibitors, the anti-androgens actually block the AR receptor. So they're blocking locally, affecting the testosterone and DHT. CYP17 inhibitors mechanistically are slightly different. CYP17 is a key enzyme in cortisol synthesis, and these enzymes are actually expressed on testicular, adrenal, and prostate tissue and are required for androgen biosynthesis. And so these are inhibitors of those. So what are the side effects related to ADT? This is sort of a broad overview. We see anemia, cognitive dysfunction, depression, erectile dysfunction, loss of libido, fatigue, GI symptoms, gynecomastia, hot flashes, lipid abnormalities, osteoporosis, and weight gain. The majority of men experience hot flashes and fatigue. Those are probably the two most common things that we see. And these can really affect quality of life, although they're not life-threatening. We do see anemia develop in these men, which tends to be pretty mild to moderate. And the other areas that we'll talk about, we'll go into a little more detail, such as osteoporosis and weight gain and cardiovascular effects. So our case study that we were talking about earlier, he experienced the following: erectile dysfunction, incontinence, hot flashes, depression, elevated LFTs, mild anemia, fatigue, and breast tenderness. So as you can see, in a really young 43-year-old, this is a lot and can really impact people's quality of life, particularly when we're talking about 2 years. So it's really important before we initiate any kind of hormonal therapy that we spend time educating patients about what to expect. We educate them about the potential side effects. The laundry list is long, but it's important so that they can anticipate as well as institute some preventative measures. We talk about dietary counseling, including calcium and vitamin D supplementation. We talk about weight-bearing exercise and resistance exercise. And then in terms of bone health, we talk about potentially obtaining a baseline bone density scan to assess their risk. So sexual dysfunction, we need to ask about symptoms. This is an area that can be, very sensitive, very difficult for men to discuss, but We know that loss of libido usually occurs, within the first several months of being on therapy, and erectile dysfunction follows. Men report decreased size of their penis, decreased size of the testicles, and we also know that recovery of erectile function is possible, but it's really related to the time in which they discontinue therapy because it's related to testosterone recovery. So this is another really key point I spend a lot of time talking to men about pre-ADT, during ADT, and post-ADT, because they want to know, when is my testosterone going to recover? And we know that the recovery is really dependent on age, duration of ADT, and what their baseline T levels were prior to initiating ADT. Mitigating sexual dysfunction. So how do we address this? Including partners is always very helpful. Phosphodiesterase 5 inhibitors really are the mainstay of our therapy in terms of drug therapy. The reason is because they're easy to use, they have a pretty favorable side effect profile, and they're on-demand dosing, so men can use it at any time. As we get further down this list, vacuum erection devices, intraurethral or corporal prostaglandins, surgical implants, we generally tend to refer to the urologists who specialize in men's health to assist with managing these. Vasomotor symptoms. This is probably our top side effect, along with fatigue. About 80% of men experience hot flashes. They describe it differently. Some people say it's a sensation of warmth. Some people say they're in a drenched sweat. But most men say, now I know what my wife experiences. It can be associated with nausea, and it can be very disruptive to sleep. So how do we address this? Well, there are options, medication-related options. Megase, venlafaxine being probably our most commonly used drug at 75 milligrams daily. There was a trial, the most extensive data that we have is a trial of about 311 men. We tend to use venlafaxine over any of these kind of more hormonal agents. We try to use these first, and we reserve the hormonal agents for refractory cases. There was also a large study done, not large, but about 300 men with gabapentin, and we found that the men on the 900 milligram dose actually had a 45% reduction in frequency and intensity of their hot flashes. So this was dose dependent. And then acupuncture, there's been some phase 2 data for that. Cardiovascular effects. So ADT we know is associated with unfavorable metabolic changes. It can decrease insulin sensitivity and cause lipid dysfunction. There aren't really any randomized trials prospectively evaluating cardiovascular disease, but the FDA did issue labeling for GnRH agonists, and that the treatment may produce a small increased risk for cardiovascular events, specifically thromboembolic events. And so although there are no randomized trials, we do educate men who are receiving ADT that this risk is there. And so we also recommend monitoring a lipid panel and a hemoglobin A1C periodically. So how do we address muscle loss? So men can have lean body mass, loss of lean body mass and increased body fat. This is usually in fat that can appear within the first year as subcutaneous adipose tissue. And they can decrease their muscle strength and decrease insulin sensitivity. And this is really related to the reduction in testosterone. So how do we mitigate muscle loss? So we recommend aerobic training at least twice a week, resistance exercises, so bands, light weights, shoulder presses, etc. And like I said earlier, we screen for diabetes and elevated cholesterol, and we often partner with primary care providers to do so. Fatigue, I mentioned, also very highly prevalent. It doesn't really seem to correlate with anemia or cognitive changes, but in one study, men reported about 14% reported severe fatigue after only 3 months of therapy. So that's really just one injection of Lupron, for example. But we do know that exercise seems to be beneficial in addressing fatigue. I mentioned anemia as well. Anemia can develop in about 90% of men, so pretty prevalent in the men who are receiving longer-term ADT. But this anemia is usually mild to moderate, and it's normochromic and normocytic. Body image. This is a really important one and often overlooked, which, I think, again, is important to ask the question. But gynecomastia and breast tenderness can develop, and it's related to the increased ratio of estrogen to androgen activity, and seems to be more prevalent in men receiving the anti-androgen monotherapy, for example, bicalutamide. But prophylactic radiation seems to help with this. Men also report decreased penile size or testicular size and can have thinning of their body hair. And this leads into sort of thinking about emotional and cognitive changes. We found that there seems to be, even though there's a sort of link, but maybe not some direct correlation. In 2019, the Society of Geriatric Oncology actually suggested that we discuss the risk of cognitive dysfunction with older men who are going to receive ADT. And although we don't think that the risk is that significant and shouldn't necessarily form your basis for whether or not you recommend ADT, it's something to talk about with your patients. And we also know that there was a meta-analysis done from about 18 studies, so looking at about 169,000 men, and there was a 41% increased risk of depression. So this is really prevalent among our patients. But if you don't ask, you don't know. And the last side effect that I'm going to talk and spend a little bit more time on is osteoporosis. I think this is a really important one. We know that ADT actually increases bone turnover, it decreases bone density, and increases the risk of fractures. So as you can see in this graph, on the x-axis, we see the duration of androgen deprivation therapy in years, and on the y-axis, we see the percentage of patients. So as you can see, as the duration of ADT gets longer in years, that red bar, the number of men having osteoporosis or developing osteoporosis gets significantly greater. So we know that loss of bone density can be detected as early as 6 to 9 months after ADT, and longer therapy can confer greater risk. So it's important that we get a baseline bone density scan. And what do we do with that information? Well, in 2008, the World Health Organization introduced the fracture risk assessment tool, or the FRAX score. And this estimates the 10-year probability of hip fracture and major osteoporotic fracture for men who are untreated between the ages of 40 and 90 years old. And so this really gives us a sense of what is this patient's risk of developing a fracture, and what can we do to. So there was a large trial done with over 1,000 patients who received Denosumab versus placebo. And the patients that were included in the study were men who were receiving long-term ADT, so greater than 12 months, who were non-metastatic and hormone sensitive with prostate cancer. What we found in this trial is that Denosumab, the men who received Denosumab, 60 milligrams every 6 months for 2 years, actually had a decrease in their risk of vertebral fractures at 12, 24, and 36 months. And actually at 24 months, the bone mineral density in the L spine had actually increased in those men receiving Denosumab by about 5.6%, which is quite good. And there have been other trials, kind of smaller randomized trials testing Zometa, but the biggest trial that we've seen done is with Denosumab. So the NCCN actually has guidelines saying that we should be screening for osteoporosis, that men who are receiving ADT should actually be taking calcium and vitamin D supplementation, and that based on their FRAX score, if they're over the age of 50, we should be recommending osteoclast inhibitors or bisphosphonates. Now I have a big red box here, and the reason is because it's very important to recognize that there's a difference between the way that we treat men with advanced prostate cancer versus those men who have metastatic prostate cancer with bone metastases. The dosing of Denosumab and Zometa and the frequency of dosing is different. So Denosumab is 60 milligrams given every 6 months in advanced prostate cancer for the prevention of osteoporosis or management of osteoporosis, whereas in prostate cancer that's metastatic to the bone, we give it every 4 weeks to reduce skeletal related events. So that's why I think that this is a really important point that often people confuse. So low bone mass, just to sort of clarify, who do we treat? Low bone mass is actually defined as a T-score between -1 and -2.5. And so those are the men that we're actually electing to treat. So what did we do for our case study? We actually intervened quite a bit on some of the side effects that they were having. We monitor the CBC and CMP and lipids and A1C. We started him on Effexor that seemed to really mitigate the hot flushes almost to having none. He was started on Wellbutrin by his psychiatrist. He uses Cialis, PRN, and has psychosocial support with a regular therapist that he's seeing, and underwent for a period of time regular pelvic floor PT, which seemed to really help with the incontinence. So in conclusion, we know prostate cancer is common. The backbone of therapy is ADT, and there are significant side effects that can impact patients' quality of life. But it's important that we provide upfront education and know that there are strategies to mitigate these side effects. And so we really need to be patient-centered and ask the question so that we can address these, particularly in men that we know are going to be on longer-term ADT, and be proactive about management. I wanted to acknowledge our team at UCSD, our GU Medical Oncology team, who has really helped shape our group and provided me with a lot of great opportunity for learning here. So thank you. And I'll take any questions.
Archana, that was excellent. Thank you so much. What an incredibly informative lecture. Really appreciate you being here today. So for our first question, do you provide men with statistics or other frame of reference as to a prediction for their testosterone recovery, or do you leave it wide open?
Yeah, so that's a great question. This comes up a lot for patients. And the way I educate patients is that it really is dependent on age, baseline testosterone level, and how long they're on ADT. So for some men, we have the benefit of knowing what their baseline testosterone was prior to initiating ADT. So the hope is that we see some recovery close to the baseline, but certainly if they're over the age of 65, I tell men that, you know, it could be months to a year or more. And for some men, we never get back to their baseline T level. And again, if it's someone who's on a longer duration of ADT, it's less likely that we're going to see that recovery if they're older. So it really is patient dependent. But I think we often are having those conversations. And I think the other thing that's telling is post ADT, depending on how quickly their first few T levels recover, we can kind of get a sense of what the slope will be.
Great. Regarding the anemia, is it worth iron supplementation?
It's a great question. So the anemia that develops with hormonal therapy is typically normochromic and normocytic. So it's not a classic iron deficiency anemia. Certainly, I wouldn't say to not necessarily work it up. If you develop or see a new anemia, I would certainly send iron studies. That's an easy fix. But most of the time, it's not an iron deficiency related anemia.
And have you experienced any problems with venlafaxine?
So some men have reported that they actually don't tolerate the 75 milligram dose. I would say that's probably less frequent, but that's typically why I start at 37.5 and then titrate them up to 75. You know, I've had patients report they get, you know, dizzy or lightheaded, their blood pressure may drop a little bit. So I would always kind of gradually titrate up to 75.
Great. And do you prefer continuous or intermittent ADT?
So that's a great question. I certainly think it depends on the situation. And typically when we're talking about continuous versus intermittent, we're talking about patients who are not in sort of that curative state where they have intermediate or high risk disease. Those are patients that we're really talking about cure. And so we wouldn't recommend intermittent at that time. The patients who receive or are eligible for intermittent ADT are people who have biochemical recurrence, who we may say, well, let's give you a period of ADT, see how your PSA responds, and then we may take you off and give you a holiday. It may also be an option for patients who just don't tolerate ADT well, but we know that long-term they're going to need ADT because this is not a curative, we're not in a curative place anymore. So it's certainly an option, but it's very patient dependent and case dependent.
And then the last question, just about the management or prevention of osteoporosis. So it's every patient gets counseled to start calcium and vitamin D supplementation, but only those who score poorly or who develop osteopenia or osteoporosis when you do subsequent bone scans, that's who you would start on denosumab, for example?
Correct. Yeah. So everyone who's starting on, and certainly this practice is variable. I wouldn't say that every oncologist makes these recommendations, but who the oncologists with whom I work closely, we often on patients, especially those that we know are going to be on more than 6 months of ADT, or even those are just receiving 6 months of ADT, we have them take calcium and vitamin D. It's the men who are really, we know are going to be on 18 to 36 months that we're thinking about, okay, let's get a bone density scan at some point, maybe at the end of your hormone therapy to see where things are.
Nice.
Mhm.
Well, that was wonderful, Archana. Again, excellent, super informative. Thank you so much, everyone. Thanks for listening to this recording. It has been great to see all of you over the last few weeks. We look forward to picking this up again in the fall, so look out for our announcements on Twitter. You can follow me at EuroPA_SD or at UCSD_urology. You can also subscribe to our YouTube channel. Go to you're probably already watching this on YouTube, but you can YouTube search APP Symposium and you can click subscribe to get more information from us and more recorded content. So thanks so much, everyone, and have a great night.
Thank you.